when we talk about scanning views, what we're saying is you're going to put the transducer, the probe, in certain locations, and you expect to get certain image. We're going to talk about the locations and the images that you're expected to get, and that is what we call scanning views. So we're going to look at the parasternal long axis view. We always start with that view, parasternal long axis, and then we're going to look at the ORV inflow view. We're going to look at the parasternal short axis view. And in the short axis view, we have short axis at the level of the aorta. We have short axis at the level of the mitral valve. We have short axis at the level of the papillary muscle, and we have short axis at the level of the apex. So when we talk about parasternal views includes a long axis. The ORV inflow view is a part of the parasternal views. Then we have parasternal short, and there are 4 views that make up the parasternal short axis. At the level of the aorta, the level of the mitral valve, the level of the papillary muscles, and at the apex. Then we go on to the apical views now. So that is when we put the transducer at the apex of the heart. We have what you call apical 4-chamber view. You can see 4 chambers. You have apical 2 chambers, where you can see just 2 chambers. You have apical 3-chamber, apical 5-chamber, and then we move on to the subcostal view. The subcostal is right where you have the xiphoid process, just below the xiphoid process. That's what we call a subcostal view. Then we have the suprasternal notch view. Just that's where we have this. We'll remember the super. So you have to remember your anatomy now. It's the suprasternal notch. Okay, so that's when you put the transducer there. We talk about the suprasternal notch view, and you can also put the transducer in the supraclavicular area. So the supraclavicular fossa, and you get images there as well. But these are essentially the views that you need to, these are the typical views that you would do when you're doing a study. Not a lot. All right, so when we talk about the parasternal long axis view, you're gonna position or place the transducer in the 3rd or 4th intercostal space. So we already went over anatomy and we know how to locate the intercostal spaces. So your transducer probe is going to be positioned in the 3rd or 4th left intercostal space, and you're going to point. There's a marker on the transducer. There's a marker, and you need to locate the marker. And when you start scanning, when you go to a machine and you locate the probe, you have to find out where the marker is on that probe. And you're going to point the marker towards the patient's right shoulder, and you're going to adjust it to get a image that I'm going to show you. Again, the transducer is placed in the 3rd or 4th intercostal space. The marker points towards the patient's right shoulder, and you make some fine adjustment, and this is the view you expect to get. So this is what we call the parasternal long axis view. Okay, so this is our 2-dimensional image, or you can call it the B mode, brightness mode. Okay, and what are the structures that we're going to see in this view? So the right ventricle is right there. Your aortic valve is right there. The left atrium is there. This is your anterior mitral leaflet. The posterior wall is right there. That's your left ventricular cavity, and that is your septum. So those are the structures that you're going to encounter when you do your parasternal long axis view. Again, the probe or the transducer is in the third or fourth left intercostal space. The marker points towards the patient's right shoulder, and you're going to just, putting it there, you probably have to make some minor adjustment to get something looking like this. And these are the different structures. All of our ECGs are, all of our echoes are done with ECG gate. And what we mean by that, everything in the heart is either systolic or diastolic. So it is gated. Everything in the heart is either systolic phenomenon or a diastolic phenomenon. So our ECG is on the bottom. Systole is from the onset of the QRS to the end of the T wave. So if you can scroll through this ECG. So anything that comes between the onset of the QRS and the end of the T wave is a systolic phenomenon. Anything that comes from the end of the T wave to the QRS is a diastolic phenomenon. So the marker is right here. So it's beyond the T wave. So the marker is right here. This is where it is. And we know that this is diastole. So from you finish your T wave when you're going to the QRS, that's diastole. And we know it's diastole because the mitral valve is open and the aortic valve is closed. Remember, the mitral valve is open and diastole, and the aortic valve is closed. So that's your parasternal long axis view. It is gated. The marker is right beyond the T wave going towards the QRS. So it's a diastolic frame. As opposed to a systolic frame, remember we said systole is from the onset of the QRS to the end of the T wave. So anything inside here is a systolic frame. So your marker is right there. It's a systolic frame because the mitral valve is closed and the aortic valve is open. There are certain things that we do in the diastolic frame and the systolic frame. In the diastolic frame, we measure septum. We measure the septum, the interventricular septum, and we measure it at the level or the tip of the mitral valve. So the tip of the mitral valve, we measure the septal thickness in diastole. Okay. You can see that it's a diastolic frame because the aortic valve is closed and the mitral valve is open. And if you look at your ECG, the marker is beyond the T wave, it's going towards the QRS complex. So that's the septum, and you measure the septal thickness. Mitral valve is open, it's a diastolic frame. Then you measure the LV cavity. This is the LV cavity internal dimension in diastole. So again, the measurement is at the tip of the mitral valve. And then you measure the posterior wall, the thickness of the posterior wall. So these are the measurements that you're going to do in diastole. These are your diastolic measurements. Again, this is a systolic frame. Systole because anything that occurs between the onset of the QRS and the end of the T wave, anything that occurs inside there is systole. And it's systole because the mitral valve is closed and the aortic valve is open. There are certain things that we're going to measure in systole as well. Okay. So this is, you want to measure, this is a diastolic measurement. So this is in narrow. Aortic root is measured in diastole, so it should have been around there. Okay. But you want to measure your left atrium. you want to measure your left atrium indiastole. And this is how it's done, okay? And you also want to measure the LV, the left ventricular internal dimension in diastole. So you're going to measure again at the tip of the mitral leaflet, the left ventricular internal dimension in systole. So you measure it in diastole and you measure it also in systole. Okay, so to get the parasternal long axis view, your probe or your transducer is in the third or fourth left intercostal space. The marker points towards the patient's right shoulder, and you just make some slight adjustments to get the image that you're supposed to get, the image that we just showed you. To get your ORV inflow view, your transducer is still in that position and you just rock it towards the patient's left axilla or the left shoulder. So these are very finesse, minuscule movements. So you just rock the transducer towards, you just move it a little bit towards the patient's left shoulder, and you get a view looking like this. This is what we call the right ventricular inflow view. Right ventricular inflow is because this is the right atrium, this is your tricuspid valve, and this is going to flow from the right atrium across the tricuspid valve into the right ventricle. This is your ventricular septum, and this is your LV cavity.
Dr.
Yes.
When you say rocket to the left axilla, you mean like turn the marker to that direction?
No, just the head of the transducer, you move it a little bit. So you just tilt it a little bit.
Okay.
So you tilt the head of the transducer just a little bit until this view comes up. So this is the right ventricle. This is the tricuspid valve. Okay, so it's your tricuspid valve. This is the right atrium. This is the left ventricular cavity. The coronary sinus is actually right there, right up here. Remember, the coronary sinus drains into the right atrium, and your inferior vena cava also drains into the right atrium, but it's a little bit above the coronary sinus. So all this is right atrium. So in this view, you can see the posterior and the anterior leaflet of the mitral valve. So we have the posterior and the anterior leaflet of the mitral valve. Okay? Again, posterior, anterior leaflet of the mitral valve, and these are the structures. So you can either, so you tilt the transducer towards the patient's left shoulder. That's an RV view. Now, so we finished the parasternal long axis view. We finished the RV inflow view, and we're going to the short axis view. So we're going to look at the short axis view. So your starting position is always that parasternal long axis view. That's your starting position, where the transducer is in the third or fourth left intercostal space with the marker pointing towards the patient's right shoulder. To get the parasternal short axis view, in that same position, you're going to rotate the transducer clockwise. You're going to rotate it clockwise to about the 1 or 2 o'clock position. The head of the transducer, you tilt it downwards. Okay? Parasternal long axis view. The transducer is in the third or fourth intercostal space. You always start with that location. Mark it towards the patient right shoulder. To get the RV inflow view, you tilt the head of the transducer towards the patient's left shoulder. To get the short axis view, you're going to rotate. You're going to rotate the transducer, and we're talking about the marker now. You're going to rotate the transducer with the marker about the 1 or 2 o'clock position, and you're going to tilt the head of the transducer downwards. This is going to give you what we call the short axis view at the level of the aorta. Short axis view at the level of the aorta. So this is the aorta. This structure is the aorta. This marker, this is actually this is what we represent the transducer. So the transducer is right there. So the computer give you the position of the transducer. Okay, and it's right there. Anyway, this is the aorta, and the aortic valve opens. This is a systolic frame. Okay, systole again is from the onset of the QRS to the end of the T wave. So systole would be from the onset of the QRS to the end of the T wave. So anything that comes inside here is a systolic frame. So the marker is right there. So it's a systolic frame. So this is the aorta, and it's a systolic frame. The aortic valve opens. This is our right ventricular cavity, or the right ventricular outflow tract. Tricuspid valve is over here, and this is your right atrium. This is your atrial septum. This is the left atrium. Okay. On this side now, you have, this is the pulmonic valve. Okay, the pulmonic valve is right there, and this is the pulmonary trunk. Remember your anatomy, pulmonary trunk, and the pulmonary trunk is going to divide it into a right and left main pulmonary artery. This is a systolic frame because your marker is right there. Okay. Systole, the aortic valve is opened. This is the diastolic frame because now the marker is right there. The end of the T wave is there. So from the end of the T wave to the QRS, that's a diastolic frame. In diastole, the aortic valve is closed. When the aortic valve closes, it closes in a Mercedes-Benz sign. Okay? Close in a Mercedes-Benz sign. Again, the right ventricle is right there. It's a right ventricular outflow tract. Sorry, it's a right ventricular inflow tract. Blood is good. This is a tricuspid valve. The right atrium, atrial septum. The left atrium is right there. Over here, you have the pulmonic valve, the pulmonary trunk, and the pulmonary trunk is going to divide to give you, okay? So the aortic valve, when it opens, the normal aortic valve, if the aortic valve has 3 leaflets, when it opens in a sort of triangular configuration. When it closes with a Mercedes-Benz sign, okay? Again, short axis at the level of the aorta. You're gonna, from the parasternal long axis view, remember your transducer is in the 3rd or 4th intercostal space. The marker points towards the patient's right shoulder. You're gonna rotate the transducer clockwise to about the 1 or 2 o'clock position, and you're gonna get this parasternal short axis view at the level of the aorta. Again, the right ventricular outflow tract is right there. Pulmonic valve is right there. That's your aortic valve opens. That's the left atrium. Atrial septum. That's your right atrium. And the tricuspid valve. So in this view, you can see this is the septal leaflet of the tricuspid valve, and the anterior leaflet is over here. So tricuspid valve, this is your septal leaflet, The anterior leaflet of the tricuspid valve is right there. So that is the short axis at the level of the aorta. So you know how to get that view. Remember, the angle of your transducer is you tilt it downwards towards the patient's leg. To get parasternal short axis view at the level of the mitral valve, you're going to move the head of the transducer up just a little bit. Again, very fine finesse movements. So you have to know the image that you're supposed to get, and you're just going to move it a little bit to get that image. So from the previous position, the transducer is tilted upwards and adjusted to obtain the image. So this is short axis at the level of the mitral valve. So this structure here is the mitral valve. Okay, again, this is your transducer right there. Okay, this is a systolic frame. Okay, so it's beyond the T wave. So this is your ECG. This is the QRS complex. This is the T wave. Systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. Your marker is right there. This is a diastolic frame. Sorry, this is a systolic frame. It is before the T wave ends. So in systole, the mitral valve is closed. Okay, so this is short axis at the level of the mitral valve. This is the mitral valve. This is a short axis of the mitral valve level, and this is a diastolic frame. The mitral valve is open. So your ECG is right there. Systole is from the onset of the QRS to the end of the T wave. So anything inside here is systole. Diastole is from the end of the T wave to the QRS. Anything inside here is diastole. In the diastolic frame, the mitral valve is open because the mitral valve opens in diastole. Okay? This is the LV cavity right there. This is the anterior leaflet of the mitral valve right there. The posterior leaflet is right down there. This is your ventricular septum. So this is right ventricle up there. Okay. Short axis at the level of the mitral valve. From the short axis at the level of the aortic valve, you're going to move the head of the transducer up a little bit, just a little bit, until you get the mitral valve coming into view. The anterior leaflet is up here. The posterior leaflet is right down there. So this is your ventricular septum. The mitral valve is right there. LV cavity. This is the LV cavity. Okay. The right ventricular cavity is right up there. Okay. So that's the short axis at the level of the mitral valve. If you move the head of the transducer upwards a little bit, so you're just going to tilt it upwards a little bit, you're going to get short axis at the level of the papillary muscles. Okay? So the transducer is tilted further upwards just a little bit from the previous position, and you're going to adjust it to get this view. Okay? So this is short axis at the level of the papillary muscles. So these little humps are papillary muscles. Okay? So short axis, the heart at the level of the papillary muscles. You have to know the different types. This is the anterior lateral papillary muscle. This is the posterior medial papillary muscle. Again, this is the ventricular septum, LV cavity, and the right ventricle is right there. Posterior medial papillary muscle, anterior lateral papillary muscle. Okay. And of course, your ventricular septum is right there, the RV cavity, LV cavity. So you were shown how to get the short axis to the level of the aorta, short axis to the level of the mitral valve, short axis to the level of the papillary muscle. Now we're going to show you how to get the short axis at the apex of the heart. So it should be a progression, it should be an orderly study. So you shouldn't be jumping from all over the place. So it should be, parasternal long axis, your RV inflow view, the short axis at the level of the aorta, short axis at the level of the mitral valve, short axis at the level of the papillary muscle, then short axis at the level of the apex of the heart. So if you tilt your transducer even further upwards a little bit more, you're going to get the apex of the heart. So the transducer is tilted even more upwards, and you're going to get something looking like this. Okay? You can't see the papillary muscles anymore, and this is the apex of the heart. So you move from the aortic valve level to the mitral valve to the papillary muscles and then the apex. And that completes the short axis. So now you know how to get your parasternal long, the RV inflow view, and the parasternal short axis view. So once you master this, then you know at least 2/3, how to image the heart. All right, so once you finish your parasternal views, so that is the long axis and the short axis, you'll take up the transducer. So whenever we scan in, we put gel on the transducer. We'll explain. We put gel because it's easy to move the transducer. We also put gel because the gel promotes the transmission of sound wave. It promotes the transmission of sound wave. So the purpose of the gel is multifold. So when you're going to do your apical views, you take the transducer, you move it from the parasternal position, and you're gonna move it to about the mid clavicular line. So you know the clavicle. If you make a perpendicular in the mid position of the clavicle and come down, you want to position your transducer in about the fourth or fifth intercostal space. So about the fourth or fifth intercostal space along the mid clavicular line. This time your marker, the marker on the transducer is going to point towards the 4 or 5 o'clock position. And you tilt it slightly, and this is the image. This is what we call our apical 4-chamber view. Again, the probe or transducer is right there. So the apical views, the 4th or 5th intercostal space, the mid-clavicular line, the marker is about 4 or 5 o'clock position, and you just adjust it a little bit. So again, you have to have good dexterity. You have to have the ability to have finesse movements, because you can't, be jerking stuff around. It has to be a nice, smooth movement. And this is the apical four chamber view. Again, the prober transducer is depicted right there. So what are the structures that we're seeing in this view? Again, it's gated. ECG is right there, and the marker is just about at the end of the T wave. So it's a systolic frame, and in systole, the mitral valve is closed, the aortic valve is open. So what are this? And then in diastole, the marker is right there, So systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So the marker is right there. So it's a diastolic frame where the mitral valve is open. But what are the structures that we're seeing in this apical four-chamber view? Okay, this is the LV cavity. This is the mitral valve. This is actually the anterior leaflet. The posterior leaflet of the mitral valve is over there. This is the left atrium. This is the descending aorta. This is the descending aorta. This is the atrial septum. This is the right atrium. This is the tricuspid valve. This is the septal leaflet. And this is the anterior leaflet. Septal leaflet of the tricuspid valve. The anterior leaflet is right there. This is the ORV cavity. This is your ventricular septum. Okay, so you have to know all the structures. And we talk about the apex of the heart. This is the apex of the heart. Apex of the heart is right up there. All right, so your apical four-chamber view. Transducers in the fourth or fifth intercostal space, the mid-clavicular line. So the clavicle midpoint, you drop a perpendicular down where it intersects the fourth or fifth intercostal space. That's where you're going to put your transducer. The marker points towards the 4 or 5 o'clock position, and you just adjust it to get a nice image looking like this. All right, so to get the two-chamber view, so the apical, so we got apical 4. To get apical two-chamber view, the position that you got your 4, you're going to just slightly counterclockwise rotate the probe. So very, very gentle, you're going to counterclockwise rotate the probe. And then you're supposed to get an image looking like this. So this is the two-chamber view, one chamber, next chamber. But you have to know the structures that make up this two-chamber view. Again, your transducer probe is right there. Okay, remember the probe is right at the apex of the heart. So this is what we'll call the inferior wall, and this is the anterior wall of the heart, and the apex is right there. So this is the apical two-chamber view. Anterior wall, LV cavity, the mitral valve, left atrium, inferior wall. So that's your apical two-chamber view. You can get an apical five-chamber view. Well, let's go to three-chamber view first. So to get apical three-chamber view, remember we said to get the two, we gradually counterclockwise, we rotating the probe. To get a three-chamber view, you just do further counterclockwise. So you got the two. If you rotate the probe a little bit more counterclockwise, you get an apical three-chamber view. And this is what it looks like. So this is one chamber, two chamber, three chamber. What are the structures that make up this three chamber? So again, this is the apex. This is in the two chamber view, this would be the inferior wall, but this is actually the inferior lateral wall. Inferior lateral wall. So in the three chamber view, this is the inferior lateral. And this is your anterior septum, okay? This is your anterior septal wall. This is the mitral valve, the anterior leaflet of the mitral valve, posterior leaflet. This is the left atrium. This is descending aorta. The aortic valve is right inside there. You have the aortic root and the ascending aorta. Okay. So what are the structures? We talk about the anterior septal wall. Okay. So the naming of the walls are different from the 2 and the 3. In the 3, this is actually the anterior septal wall. And the reason for getting the different views, you need to see the different structures of the heart. You need to see the different walls. Because if you have a heart attack can, heart attack is when you get a blockage of the blood vessel around the heart. It's going to affect a specific wall. So in some views, the walls may look perfectly normal. But when you see a wall, say you see the inferior wall, and the patient had an inferior wall heart attack, then you'll see that it's not thickening, it's not moving properly. So this is your anterior septal wall, the left ventricular cavity, the aorta, the left atrium. This is the mitral valve, but this is actually the anterior leaflet. The posterior leaflet is right under. And this is your inferior lateral wall. So you have to know the different structures that make up the. So we talk about the apical 4, we talk about the apical 2, and we talk about the apical 3. Now we're going to the apical 5-chamber view, and this is a very easy view to get. So where you locate the apical 4-chamber view, so you know the fourth or fifth intercostal space, the mid-clavicular line, mark it towards the 4 or 5 o'clock position, and you got your apical 4. If you just gradually move the head of the transducer downwards, if you just move it just a little bit, you get a 5-chamber view. So from the 4-chamber view, you're going to tilt the transducer downward, and you're going to adjust it to get this view. And 5-chamber view is because the left ventricle, left atrium, we actually open in the 4-chamber view. We actually open the aorta. So this is the aortic valve. The ascending aorta is right there. The RV cavity and the right atrium. So the 5-chamber view is very important. So you have to know how to get it. So the mitral valve, the posterior leaflet of the mitral valve is here. The anterior leaflet of the mitral valve is right there. Okay. You can see the pulmonary veins. The pulmonary veins, remember, drain into the left atrium, and you can see the pulmonary veins. So you can see the pulmonary vein. Again, this is the aortic valve. We open the aortic valve. The anterior leaflet of the mitral valve. And of course the LV cavity, the ventricle, the septum, the right ventricle, and the right atrium. The important thing, I don't know if you've seen a structure right there. This is the moderator band. The moderator band is in the right ventricle, and when you get your 5-chamber view, you can see the moderator band. Okay, there's something I need to show you guys. So when we did anatomy, we said the tricuspid valve, you can locate the right ventricle by looking at the valve that is lowermost in the ventricle. So this is what we mean. If you look, this is our apical 4-chamber view. When you're doing a scan, when a patient comes to the lab and you're scanning the patient, you're not going to see these labels. It is not going to be labeled. You're going to get a heart, and you have to figure out what cavity is what cavity. Okay? And you're going to see a patient's going to come in with congenital heart disease, and things are probably not going to be in the position that you thought they were going to be in. So when you get a heart like this, we know that this is a atrioventricular valve. This is another atrioventricular valve. But this valve, if you look closely, it's actually lower in the ventricle than this one. So this valve being lower in the ventricle, you see it's a little up, a little bit. So being lower, this tells you that this is the tricuspid valve and this is the right ventricle. So if this is the right ventricle, then it's going to be the left ventricle. If this is a tricuspid valve, then this is a mitral valve. So you have to know where things supposed to be located and try and figure out which is which, because you have transposition of the great vessels, you have things like tetralogy flow, you have things like Epstein anomaly, you have congenital stuff that patient come to the lab and you have to figure out exactly what's going on. Okay, so the tricuspid valve is lowermost in the ventricle than the mitral valve, and that tells you that this is the right ventricle. So we did our apical 4, apical 2, apical 3, and apical 5. So we're finished with our apical views. So you should be able to scan a patient now, because we already did the parasternal, long and short, and then we did our apical, and so that's about 80% of the scanning. So once you can do those, then you can scan. All right, so the next view is what we call the subcostal view. The transducer is positioned just below the xiphoid process. Okay, it's placed just below the xiphoid process, and your marker points toward the patient's head, and you're going to adjust, and you get a view looking like this. A very important view. This is the liver. Okay, so we can look at the liver. So this is the liver. This structure that's traversing the liver is the inferior vena cava. IVC, inferior vena cava, and this is an hepatic branch. So inferior vena cava, hepatic branch. Remember, the inferior vena cava drains into the right atrium. It drains into the right atrium. Okay, so the inferior vena cava drains into the right atrium. So subcostal, you put the probe in subcostal, the marker towards the patient's head, and you get this. So the liver, the right atrium, hepatic vein, the inferior vena cava, IVC. Then we have to measure. It's very important to measure the IVC, because that's by measuring it, we can deduce the right atrial pressure, and it's very important to report the right atrial pressure in most patients that come to the echo lab, because if someone have pulmonary hypertension, you have to correctly determine the right atrial pressure, and even for normal patients, you should do it as well. So you have to measure the IVC, and you measure IVC just beyond the hepatic vein. Okay. Then from the IVC view, you turn the transducer clockwise. You're going to tilt it and adjust it to get an image looking like this. So again, this is the liver over here, but now you can see the right side of the heart. Remember, the right side of the heart abuts the liver, and then this is the left side of the heart. This is a very important view, because you can see the ventricular septum and the atrial septum. So if the patient has atrial septal defect, this is a good view to get. Also, you can look at the pericardium. Patients have pericardial effusion. This is a very important view to get as well. So that's the liver right there. The right ventricle is right there. Ventricular septum, LV cavity, atrial septum, the left atrium, right atrium. Very important view. Okay, so we look at the subcostal, looking at the IVC, and then looking at the right side of the heart. Then the the final view. So, you've learned to scan in less than 1 hour. So the the suprasternal notch view, suprasternal notch. So you put your transducer in the suprasternal notch, and the marker points to the patient's head, and you turn the transducer to the right, and you're going to adjust it, and you're going to get, this probably doesn't project very well, but if you follow me, the ascending aorta is right there. The ascending aorta is right there. 1 second. All right, so the ascending aorta is right there. This is the arch. So the aorta ascends, then it bends. This is the arch. And then this is the descending aorta. The aorta descends. Okay? This is your right pulmonary arch right there. This is a crucial view because if your patient have coarctation of the aorta, coarctation is usually right about here. Okay? And then not only that, if your patient have a dissection, you can also look at the descending aorta. Okay, you can see the ascending aorta, the arch, and the descending aorta. So very important view. So ascending aorta, the arch. So remember the vessels that comes off the arch. Okay, over the side you're going to have the innominate, and the innominate is going to split to give you the right subclavian and the right common carotid. But this one is the left common carotid, and this is the left subclavian, the descending aorta. Very important view. So that essentially covers the how we scan the heart. So once you master these and you know how to get them and get good images, then you're 50%